Dr. Christie, you talked in your delivery about having to make decisions about whether you would or wouldn't operate in certain circumstances if someone had a tumour, whether it was local or embedded or whatever. What's the difference with Charlie Teo in terms of what he does?
No difference. He's one of many neurosurgeons. Yeah, and there are. But you're right. There are differing viewpoints on what people would regard as an acceptable side effect for having their surgery. So that's a conversation, and that's a conversation I have with some patients. If I know that this tumour is likely to be going into an area which is what we call eloquent, in other words, where some function occurs, and I'll say to that person, if I sort of, get a bit more aggressive with this has a risk of leaving you with some functional disturbance in that area. Is that acceptable to you or not? And I think that's probably the conversation you have to have. The only difference is that, all the other neurosurgeons don't get on the television, I think.
Just have a quick one. Don't need a microphone, I'm pretty loud. With regards to the tissue and organ donation, with cancer, I don't think you're acceptable for organ donation, is that correct?
No, it's not. So it depends. All cancers it's possible. The correct answer is no one is excluded based on their cancer today because everyone's situation is different. As we discussed, there are some cancers that we know don't spread to the other organs in the body, and therefore that person might be able to donate their organs. So what we don't want anyone in our society to do is say, I've got this, therefore I can't. What we'd prefer you to say is, I'd like to do this, and I'd like the medical and nursing staff at the time of my death to see whether anything can be donated. Rather than saying I can't do it, we'd rather you say what your wishes were and then let us decide whether you're medically suitable to do that at the time of death.
Thank you. In my case, I have anaplastic astrocytoma, so it would be unlikely if someone needed a heart, that my heart would not be suitable because my heart's probably still quite healthy.
Dr. Christie might know more about the metastases of the anaplastic astrocytoma than I do.
Sure, your heart is healthy, the amount of kilometres you cycle. It's almost unheard of for glioma to spread to outside the brain or what's called the neuraxis. I think there have been something like 2 reported cases in the whole literature. So I think, basically, everyone else, all your other organs that are likely to be candidates for transplantation, I guess I would regard as being acceptable.
It's certainly done on a case-by-case basis, and of course, there's some brain cancers that we know very rarely move outside the brain, but sometimes they do. So again, it's just every person is assessed at the time of their death as to what is suitable, and as I said, we'd prefer that our community discuss whether they want to do it and then let the health professionals at the time, because there's certain risks that transplant surgeons are prepared to take. If you've got a young 19-year-old who needs a liver today, or they're going to be dead tomorrow, and you've got a person with a brain cancer which is very, very rarely metastasised, they're probably going to take that risk of saving that 19-year-old. But it's done on a day-by-day basis based on who needs what, who needs when, what the risks are, what we perceive the benefits to be, and how we can do it on that day. So that's the important message, I think, to know about.
Thank you for that. That's another form. I've filled out all the other ones.
Excellent. Another form I've got for you.
I read up on it and they sort of said it's not exclusive, so I hadn't done that part, so I'll sort that one.
Great.
Any other questions from anyone?
I've got a question about ACPs and Advanced Care Directive. What if you do them and the doctors turn around, which has been my experience when I was working in hospital, and they don't take them as a legal form? They just go, no, I'm not following that.
Well, my hope would be that if it was a formal legal advanced care directive, that would be considered at the time. But the important thing that I teach doctors all the time is as I said to you, we need to know that it means that for this current situation. So there are certain... this is the problem with writing things down, as I said earlier, is circumstances change. And if I write an advanced care directive today that says I never want to have IV antibiotics because I've got these other terrible diseases and I don't want IV antibiotics, but then I get a raging urinary tract infection, which is excruciatingly painful, and we know that having 48 hours of IV antibiotics can fix that pain, then it's very reasonable for a medical officer to say this is an acutely reversible condition and we can fix this for you and stop your pain and make it better. However, a directive that says that legally means that you can't give the IV antibiotics. So what we then need to be doing is saying to the family, the enduring guardian, the person responsible, you know, mum or your wife has said that she doesn't ever want to have IV antibiotics, but we think we can fix this urinary tract infection quite easily. And are you happy for us to just try this for 48 hours, and if it doesn't work, we'll stop the antibiotics? But we think we need to talk about this advanced care directive because we're unsure if it actually should be applied to this reversible condition. Does that make sense?
No, it's just when I was nursing it, it's not quite. Medicos would be...
Look, I think I would be a liar if I told you that we have this space completely under control. And I'm not going to tell you that we do. But what I am trying to encourage is that the most important thing for me, as I said, is appointing that person who can have a conversation with the medical teams, knowing what you want. Because I think the problem with writing anything down today is tomorrow your circumstances could be different. And so for me, it's more important that the conversations are continuous and that we're continuously talking to patients and to the significant people that they have appointed to look after their medical decisions, rather than saying that this directive must be followed at all costs. We don't have great systems within the hospital for accepting these forms into our hospital system. We're working on that. We are trying to make this better for our community. We're trying to make it better for our doctors who end up with plans that sometimes don't make any sense in a medical hospital environment.
Like a 305-page legalese document presented to emergency doctors that they've got to read through before they save this person's life. And by the time they have their legal team come in and read it, then the document is invalid because the person's died.
It can be really difficult, and as I said, we don't have this space completely under control. We're trying to get better at it. We're continuously trying to work at encouraging these conversations, encouraging a society that can actually talk to each other about these important issues, which is something Australian people have not been very good at. We need to talk about this stuff. We need to talk about death and dying, because if we don't, then we find ourselves in hospital environments with nurses, with doctors, with patients, with families, where no one knows what they're meant to do. And no one knows what we're meant to do at this critical period of time, and the default position is always to fix in hospital. It is always to go in with all guns blazing to try to fix, unless our doctors say we actually can't fix this. But generally, if we're a bit unclear, we're always going to give things a go to try to fix it. So this is a really difficult space to work in, and I'm not going to lie and tell you that we're really great at it. All I want you to do, though, is think about who can talk for you and what you want and what your wishes are, so that we can try to incorporate that into our healthcare plans.
My question's for Dr. Christie. You've already said it's up to, when you operate, it's an individual thing, but how many times can you actually go in and debulk tumours, or is there a limit on it? Or
No, there's no actual limit that says you can do it two or three or four times. For gliomas, there are people that I've operated on 4 times. Should I have operated on them 4 times? I'm not sure. So I think each time it becomes the same conversation. Do you think is there likely to be a benefit to that person from the intervention? And so, that's the question, I think, rather than there being a defined amount of time that you can do something. Having said that, from people who have had some different tumours, who've had numbers of operations, my experience over the years is that after a certain amount of times, our brain doesn't like being interfered with too much.
Can you induce death?
By operating? Yes.
No, by a drip.
That's probably not the question for me.
The answer to that is no, euthanasia is not possible in this state.
Can you do it at home?
No. Would be the... So legally, it is not allowable in this state for us to cause death by using medical procedures.
But like if you've got a morphine infusion going.
If you've got a morphine infusion going, morphine does not induce death. So that's a really, really important thing.
And you increase it?
It does still not induce death, and in fact some studies around the use of opioids show that you can live longer with good pain management. So morphine, even in countries where they have euthanasia, it is not morphine that is used to induce death. They do not use morphine because morphine is a pain relief and will not necessarily cause death.
We haven't got it in this state, have we?
No.
Thank you so much for attending today. Again, we've had people travel here from Tamworth and Port Macquarie and Coffs Harbour, so it just goes to show there's such a huge need, and we really appreciate all of you coming today. It really took a lot for each of you to be here, so we truly appreciate it. And just remember, like I said at the start, you're not alone. We're all in this together. So if there's anything you need, you just ask your specialist and ask Alicia. We're always going to be here for you. We don't just stop being there for you. We're here for the long run. So we'd really like to and we really appreciate Jeanette. That was an amazing talk. We really hope that this sparks conversations between all of you because it's so important. I've even had the conversations with my husband as well. He knows my wishes. We've done our will, and as we know, look at us all, anything can happen. So it's really important that your loved ones do know what you want at that time that you can't decide. And Dr. Christie, as always, that was excellent and so practical, and just to have an insight to know what actually went on to a lot of you while you're asleep. So thank you again for coming today, and we hope you got something out of it. And again, please fill out the evaluation forms. It's the only way we know if we're doing a good job or not. And either leave it on your table or give it put on the front desk on your way out. So please travel home safely and keep fighting. Thank you.